Hi, I'm Dr. Janet Pope. I'm reporting for @RheumNow, and my Twitter handle is @JanetBurdo. And this is an exciting month of September with respect to learning a lot about ILD in our patients. So, what about assessing and staging patients with ILD in your practice? So, let's start a bit with a case. I have a 52-year-old man. He's had diffuse cutaneous systemic sclerosis, so the diffuse subset of scleroderma, for about 3 years. He has ILD, and he asked me, how severe is it? He also asked, is this going to kill him? Because he's now work disabled and he really needs to know with respect to a will and trying to have funds for his families. So there is a side note that's of interest. He did work for about 30 years in window manufacturing in a factory, and any production of silica dust is an increased risk for both ILD, not just silicosis, but ILD also for scleroderma. So I did suggest he see occupational health, and he went forward with a workman's compensation claim. However, back to the story. So he's been on mycophenolate mofetil with repeat dosing of rituximab, and his PFTs have improved by approximately 7%. When we look at his HRCT, he has an NSIP pattern, so the nonspecific interstitial pneumonia. So how am I going to stage him, and what should we do, and how should we be systematic? And then how do I answer his questions about how long has he got, doc? So, how do we help answer this prognosis? Well, unlike idiopathic pulmonary fibrosis, there isn't really universally accepted staging for connective tissue disease associated interstitial lung disease, or what we say is CTD ILD. So I think it's important to be systematic. So I look in several areas: symptoms, imaging, pulmonary function testing, and maybe biomarkers. But if you're not doing research, even following a C-reactive protein that you'd follow anyway at times is important. So what about symptoms, the clinical assessment? It's important to ask about dyspnea, and you can't just say, are you short of breath, or people take it literally right here sitting in front of them. You have to say things like, compared to last year, is it more difficult to do? And then you say activities. So you want to know if things have changed, and you want to know, is it exertional with mild or moderate exertion, or even just doing activities of daily living, or having a shower and getting dressed, or even at rest. It's also important to ask about cough. Cough is a poor prognosis if it's chronic in our patients with ILD, with their connective tissue disease, and ask about fatigue. Then we do think about functional status. So just like we would do a hack for someone with rheumatoid arthritis, we're going to look at function. You can do an oxygen sat. I'm not going to do it on the hands of scleroderma patients because they have thick skin and Raynaud's. So you can do the sat on their earlobe, or you can do a sat after they walk around. And then I'm going to look at disease activity. For instance, this patient has scleroderma, but other CTD or rheumatoid arthritis. Is there active arthritis? Is it active myositis? Is there active lupus, etc.? And basically, if it's someone with rheumatoid, you want their disease in remission wherever possible, so that will prevent or slow progression of the lung disease. Okay, what's next? Pulmonary function test. Now, I don't think you need to master pulmonary function test, but there's some things you want. I want both flows, which are done routinely, but I also want volumes. So you want to look at FVC, percent predicted, or the forced vital capacity. And by the way, it's very similar to usually in our patients, to the TLC, the total lung capacity. And I'm looking at percent predicted because I want to know change over time. I pay a lot of attention to the diffusing capacity. And there are staging cutoffs that are sometimes used: mild restrictive, where DLCO is still greater than 60%, FVC percent predicted is greater than 70%. And if you remember, 80% predicted to 120% predicted might be normal in an individual if you don't know where they started before they got their ILD. And then you would stage moderate or severe. And severe is pretty poor prognosis in general. FVC percent predicted less than 50%, DLCO percent predicted less than 40%. However, what's even more important are the changes over time, which is why I'm asking about functional dyspnea over time, but also PFTs over time. So we have a few rules in scleroderma, and they've been used in these ILD trials, including RA patients or other patients with UIP or R types of patients. So a decline of FVC percent predicted of greater than 10% in a short period of time, like 6 or 12 months or even 24 months, that is maintained as opposed to reversible if they had a cold or something and then it improves. That is significant progression. Or a decline of the diffusing capacity greater than 15% predicted in the same time frame. One or either or both is a bad sign. Okay, then I'm going to also stage by high-res CT scan. Now, again, you might look at the scan, but you certainly will read the report if you're ordering it, and you want to co-manage for the PFTs and for the HRCT with your local smart pulmonologist, and you better find one you can work with. It's a good idea. So patterns matter. And the extent matters. So an NSIP pattern is better than a UIP pattern. So NSIP is the non-specific interstitial pneumonia, and that's the most common pattern for many of our patients with connective tissue diseases. RA patients still have almost equal usual interstitial pneumonia, UIP. That's the more progressive fibrotic pattern. And scleroderma patients have a little bit more NSIP, but any of our patients could have either pattern or a mixed pattern. So that's important, the pattern. Then the extent is important. So how much of the lung is involved? So usually it's the bases. We're looking for honeycombing. That's a bad sign if you see that word or that phrase. And traction bronchiectasis is also in general a bad sign. Our scleroderma patients already have a dilated esophagus, so that would probably be mentioned as well. And we're looking to see if there's also superimposed aspiration, which is more in the mid zones, whereas the NSIP or the UIP start at the bases. So what do radiologists tell us if we ask? Is this, again, thinking mild, moderate, or severe, less than 20% involvement versus 20 to 40% or greater than 40%? Each of those patterns, and some patterns being worse than others, and the extent is really important. And where their PFTs are at is important, but how fast they've gotten there, so the change over time is important. Okay, what else should we do? I think doing periodic echocardiograms, which I would do in this patient anyway because he has systemic sclerosis and we monitor for pulmonary hypertension. But two bad problems in your lungs are far worse than one. So pulmonary arterial hypertension is often group 3 in our patients with ILD and scleroderma because of hypoxia. But some patients have a vasculopathy kind of pattern, and then they might have hypoxia out of keeping with their ILD. So that's really difficult, and we need expert people to help us with that. And obviously, if you suspect pulmonary arterial hypertension by the echo and dyspnea, maybe, hopefully not, but maybe JVP's up or pitting edema, so signs of right heart failure, we would like to diagnose it before then. Then you get an expert in pulmonary arterial hypertension to help you, and they have to do a right heart cath. The other thing, and again, when I say to do it, this doesn't mean you need to do it. You need to work with your pulmonologist, but checking for hypoxia regularly. And what do we think about checking at rest? And again, avoiding their fingers with the SAT monitor if they have scleroderma, try their earlobes, or you can do an arterial gas, more invasive, of course, though. But I look at rest, I look walking them around a bit and then checking with the SAT on while they walk. They just carry it around with them. And a lot of the automated blood pressure cuffs that you might have in your office will have a SAT monitor on it as well. And also lying down. Some people are quite hypoxic at night, so you might want to check lying down. What's really important, though, is a multidisciplinary approach. So we need the pulmonologist, the rheumatologist, and we often involve the radiologist. And really, we have to also say, who's responsible for what? Am I going to treat the scleroderma and you're treating the lungs? Am I going to do both? What are we going to do? And then never forget about general care. And this is true for any of our CTD or RA patients with ILD. Vaccinations, so flu shot regularly, an age appropriate flu shot. Over 65 gets a stronger flu shot. COVID vaccines regularly, the pneumonia shot. So that's now Prevnar 20 is the one. It's one and done, even if they've had the Pneumavax before in our immune suppressed patients with ILD. Exercising regularly, you can get them off to a program, even though they don't have obstructive lung disease and might not have coronary artery disease. Just get them in a heart failure program, coronary artery disease program, or a COPD program if there is no ILD program. Avoiding others who have infections, breathing exercises, so deep breaths are important. Warning the patients of worsening signs like pitting edema, chronic cough, or signs of infection, so new sputum, change in sputum color, fever, and identifying and treating hypoxia. So I think this will help where you're going to frame how a patient is doing. So let's go back to my patient, 52 ILD. Fortunately, on MMF and rituximab, he has actually improved and he feels better. He has an NSIP pattern and it's less than 20% on his HRCT. So he's got a good prognosis because PFTs have improved and so have symptoms. He doesn't have a chronic cough. He's not hypoxic. He is a non-smoker. He has an NSAP pattern, which is better than a UIP pattern, and he doesn't have much extent on HRCT. What if he worsens? Well, in addition to rituximab and MMF, then I would think, is this progressive pulmonary fibrosis? Does he need something else like nintedanib? Is he worsening because there's a superimposed infection? Is he worsening because something else is going on? So you look at other chronic low-grade infections, meds, etc. So I think this gives you a framework in which to be an excellent co-manager on your patients with CTD ILD. For this, I thank you.